Okay, let's dive in. That knee pain a lot of us feel sometimes, especially if you're active.
Oh, yeah, it's super common. Patellofemoral pain or PFP. So many people who, like to run or jump deal with it.
Right. And what's kind of wild is, even though it's so common, nailing down exactly why it happens.
And what the absolute best fix is.
Yeah.
Yeah, it's still pretty debated. Lots of different theories flying around.
Exactly. Which is why this is such a great topic for a deep dive. We got a paper sent in by a listener,
Oh,
actually.
nice. What's it called?
It's titled The Influence of Altered Lower Extremity Kinematics on Patellofemoral Joint Dysfunction, a Theoretical Perspective.
Yeah.
Bit of a mouthful.
Huh. Yeah, sounds academic, but sounds interesting too. Kinematics. So, movement.
Precisely. And what really struck me is this idea that maybe we've been focusing too much just right on the knee.
Well, that's the traditional approach, isn't it?
Yeah.
Knee pain, look at the knee, strengthen the quads, maybe some tape, that sort of thing.
Yeah, but this paper throws a bit of a curveball. It suggests PFP isn't just a knee thing.
Okay, I'm intrigued. Where else are they looking?
Well, this is the cool part. It looks at how your hips, your pelvis, even down to your ankles and feet, how their movement and alignment.
Can actually mess with your kneecap.
Exactly. It's like the whole system is linked, your foot bone's connected to your ankle bone, and eventually it affects the knee.
Okay, that makes sense conceptually, like a chain reaction.
Mm.
But why look so far away if the pain's right there in the knee?
That's what the paper digs into. The argument is that your leg works as one unit, basically, a kinetic chain.
So something funky happening at the foot could have this knock-on effect higher up.
Precisely. So our mission today is to unpack that. How can these mechanics, from the hip down, really influence that patellofemoral joint?
And hopefully understanding that connection could point towards maybe better, more lasting solutions for folks with knee pain.
That's the goal. So where does the paper start?
Okay, it kicks off with this concept called the law of valgus. Can you break that down for us?
Sure. So basically, just because of how our leg is built, there's a natural tendency for the kneecap patella to get pulled slightly outwards.
Outwards, okay. Why is that?
Well, think about the main forces. You've got your big thigh muscles, the quads pulling upwards, and the patellar tendon pulling downwards below the kneecap.
Right.
But those lines of pull aren't perfectly straight up and down relative to the kneecap's groove. There's an angle.
Ah, okay.
And this angle creates a net force pulling the kneecap sort of sideways, outwards. Figure 1A in the paper shows it pretty clearly.
Gotcha. And isn't that related to the Q angle people talk about?
Exactly. The Q angle is basically how clinicians try to measure that sideways pull.
How do they measure it?
They draw lines. One from a point on your hip bone to ACES to the middle of your kneecap,
Okay.
and another line from that bony bump on your shin, the tibial tubercle, up to the middle of the kneecap again. The angle between those two lines. That's your Q angle.
And a bigger angle means more outward pull.
Generally, yeah. A larger Q angle suggests a stronger tendency for the patella to want to track laterally towards the outside.
Okay, seems straightforward. Bigger angle, more outward pull, more likely to have tracking problems and pain.
But here's where it gets murky. The paper points out that the link between the Q angle size and actual PFP symptoms, well, it's not that clear-cut in the research.
Really? So a big Q angle doesn't automatically mean knee pain?
Nope, it's not a guarantee. And the paper gives a few reasons why this connection might be weak.
Like what?
Well, for starters, how you measure it isn't standardized. Standing, sitting, muscles tight, muscles relaxed, you get different numbers.
Consistency issues.
Big time. Plus, it's usually just a static measurement, right? Like a photo. It doesn't show what's happening when you're actually moving, running, jumping, squatting.
Right, when those forces are actually highest.
Exactly. So the takeaway isn't that the Q angle is totally useless, but maybe it's just one small piece. Focusing only on that static number might be why finding answers for PFP has been tricky.
But the paper does say something about when the knee is bent, right? Like over 20 degrees.
Yeah, good point. It mentions that beyond about 20 degrees of knee bend, a larger Q angle can increase the pressure on that outer part of the patella where it meets the femur.
Okay, so it can matter in certain positions.
Definitely. And interestingly, they also mention that a Q angle that's too small can also cause issues. It's about finding that sweet spot for tracking.
Right, it needs to glide smoothly in its groove.
And they add that if the patella isn't sitting well in that groove to begin with, maybe it's positioned too high or the groove isn't deep enough, then a really strong quad contraction combined with that larger Q angle that could potentially even make the kneecap pop partly out of place. Subluxation.
Ouch. Okay, so Q angle gives us a clue, but it's definitely not the whole picture.
Not by a long shot.
So the paper then starts looking at things away from the knee that could influence that Q angle, like tibial rotation. How does the shin bone turning affect the knee?
Right. Remember, the Q angle measurement involves the tibial tubercle, that bump on the shin where the tendon attaches.
Yeah.
So if your tibia, your lower leg bone, rotates, that attachment point moves.
Ah, makes sense.
If the tibia rotates outwards, external rotation, the tubercle moves out, making the Q angle bigger.
Okay.
If it rotates inwards, internal rotation, the tubercle moves in, and the Q angle gets smaller. Figure 1b shows this well.
Okay, so shin rotation changes the Q angle. And the paper connects this tibial rotation to the foot and ankle, right? The subtalar joint.
Yes, that's a key connection. It explains that internal tibial rotation usually happens with foot pronation, when your arch flattens and your foot rolls inward.
Right, like when you first step down.
And external tibial rotation tends to happen with supination, when the foot rolls outwards, lifting the arch. It's a coupled movement.
Part of normal walking and running biomechanics.
Exactly. The paper even notes that in early walking, like the first third of your step, it's totally normal to pronate a bit.
And the tibia rotates inward along with that, like 6 to 10 degrees.
Yeah, something like that. It's just how the ankle bones move together.
Okay, but here's where my head starts spinning a bit. There's this common idea, right, that excessive pronation, like overpronation,
is bad for your knees. Yeah, you hear that a lot. Leads to a bigger Q angle and stress on the kneecap.
But the paper challenges that.
It does. It actually argues that excessive internal tibial rotation, the kind you might get from overpronation,
would actually decrease the Q angle.
Yeah.
And reduce those outward forces.
Yeah. Seems backwards, doesn't it?
Yeah, it really does. So how could overpronation still cause knee problems then?
Well, the paper brings in Tiberius theory to try and bridge that gap.
Tiberius theory. Okay, what's the idea?
So think about walking. When you're in mid-stance pushing off, your knee needs to extend, right? And to do that efficiently, the tibia normally needs to rotate externally a bit relative to the femur. It's part of the knee's locking mechanism.
Okay, the screw-home mechanism.
Right. Now, Tiberius' idea is, what if your foot stays pronated? What if it doesn't resupinate, doesn't roll back outwards like it should?
Then the tibia can't easily rotate externally.
Exactly. It's sort of stuck in internal rotation because of the foot. So to compensate and still let you straighten your knee,
the femur rotates internally on top of the relatively fixed tibia.
That's the theory. And that internal rotation of the femur, as shown back in Figure 1c, would increase the Q angle and the outward pull.
Ah, so it's not the pronation itself, but the body's compensation for the lack of resupination that causes the issue higher up.
That seems to be the argument. It's a chain reaction, where the foot's behavior forces a compensatory move at the hip and femur, which then impacts the knee.
That's a really neat concept, but does the evidence always back that up? Is it always that neat one-to-one link?
Well, the paper is careful to point out that it's not always so simple. They cite a study by Reichel that found the amount someone pronates doesn't always predict how much their tibia or femur rotates. And tibial rotation doesn't always predict femoral rotation either.
So it's not a perfect correlation. There's wiggle room.
Exactly. The paper highlights that the knee itself can absorb some of these rotations. It's not just a simple hinge.
And didn't it also mention variability in how much the tibia rotates compared to the foot?
Yeah, different studies found different ratios between rear foot movement and tibial rotation. It varies between people and activities.
So the link is there, but it's complex and variable.
Right. And then they look at studies comparing people with PFP to those without.
Like Messier and Powers. What do they find about pronation?
Interestingly, they often didn't find significant differences in the overall amount of pronation between the groups.
So maybe excessive pronation isn't the main culprit for everyone with PFP.
That seems to be the suggestion. It might not be the universal driver we sometimes assume it is.
But it could still be a factor for some people.
Absolutely. The paper acknowledges that. They mention a study by Eng and Piranowski.
What did that one show?
They found that using orthotics, arch supports, along with exercise, worked better for PFP than just exercise alone.
Ah, so for that group, addressing foot mechanics clearly helped.
Exactly. So it seems like it's a factor for a subset of individuals, but maybe not the whole story for everyone.
Okay, so tibial rotation and foot mechanics are one piece. What about rotation higher up? At the femur, the thigh bone. The paper suggests that might be even more important.
Yeah, it really digs into femoral rotation. And just like the tibia, the femur rotating can also tweak that Q angle.
How so?
If the femur rotates inwards, internal rotation, it effectively moves the kneecap's groove inwards relative to the hip point, ACES, which increases the Q angle.
And outward rotation would decrease it, like we saw
Yeah.
in Figure 1C again.
Right, but the paper stresses that femoral rotation's influence isn't just about the Q angle.
Oh, what else does it do?
It can directly affect how the patella sits and moves in its groove, kind of independent of the tibia's position.
So the thigh bone rotating can directly push the kneecap around.
Sort of. And that dynamic MRI study by Powers they mentioned earlier really drives this home.
Right, the one looking at people with unstable kneecaps.
Yeah. They found during weight-bearing stuff, like a single leg squat, it was mostly the femur internally rotating that caused the patella to tilt and shift sideways.
Not the patella moving on a stable femur, but the femur moving under a relatively stable patella. Figure 2 showed that, right?
Exactly. And that's huge because it flips the perspective. Maybe the kneecap isn't always the bad guy moving out of place. Maybe the house that lives in the femur is moving underneath it.
That really challenges the way we usually think about patellar tracking. Fascinating.
And there was another study, Lee et al., on cadavers.
What did they find?
They found that forcing significant femoral internal rotation, like 30 degrees, really increased the pressure in the patellofemoral joint when the knee was bent.
More pressure, more potential for pain and wear. Makes sense.
They also simulated femoral anteversion. That's like a structural twist in the femur bone itself that leads to internal rotation.
Mm-hmm.
They saw a similar trend of increased pressure, though it didn't quite reach statistical significance in that particular study.
Okay. So femoral internal rotation seems potentially problematic. Does it happen normally?
Yeah, the paper says during normal walking, the femur does rotate internally a bit in early stance. But again, lots of variation.
And it revisits that compensation idea, right? That maybe the femur rotates in too much because of issues down at the foot or ankle.
Exactly. It keeps coming back to that interconnectedness.
But what causes the femur to rotate internally, besides compensation?
Now we get to the muscles. The paper highlights the hip muscles, specifically weakness in the ones that rotate the femur outwards.
Like the glutes, gluteus maximus and the deeper rotator muscles.
Yep. If those external rotators are weak, the femur can just sort of roll inwards during standing or walking. Passive internal rotation.
Okay, so weak butt muscles can lead to knee issues. We hear that a lot in rehab circles.
Definitely. And they also mentioned structural things like that femoral anteversion we talked about. If your thigh bone is just built with more of an inward twist,
you're predisposed to rotate internally and maybe walk a bit toed in.
Exactly. It sets you up for that pattern.
But didn't the paper mention a study that found something surprising about femoral rotation in people with PFP?
Oh, yeah, that was interesting. The one study they cited that actually measured it during walking in PFP patients found they had less internal femoral rotation compared to controls.
Less. That seems counterintuitive if internal rotation is supposed to be bad.
I know. The authors speculated that maybe it was an unconscious strategy. Like their bodies were trying to avoid internal rotation to reduce the Q angle and take stress off the kneecap.
A protective mechanism almost.
Potentially.
No.
But again, the key finding was lots of individual variation. No single pattern fits everyone.
Okay, so femoral rotation is clearly a big factor, influenced by muscles, structure, and maybe compensation. What about side-to-side movement? Knee valgus, or knock knees?
Right, moving into the frontal plane now. Knee valgus, where the knees angle inwards towards each other.
How does that affect the Q angle? Figure 1D touch on this.
Yeah, if your knee moves inwards, valgus, it shifts the patella more inwards relative to that fixed point on your hip, the ACES.
So valgus increases the Q angle.
Correct. And conversely, if you were bow-legged knee varus, that would potentially decrease the Q angle.
And this valgus movement, it can come from the thigh bone angling in or the shin bone angling out.
Exactly. The paper makes that distinction. Femoral abduction, thigh moving in, or tibial abduction, shin moving out, or sometimes a mix of both.
And they had those figures 3 and 4 showing what that looks like during things like landing or stepping down. That visual really helps.
It does. You can picture that knee diving inwards.
So what causes that excessive inward movement? Again, muscles.
Often, yes. Especially that inward movement of the thigh bone, the femoral adduction, that's often linked to weakness in the hip abductors.
The muscles on the side of the hip that pull the leg outwards, like gluteus medius.
Glute medius is the big one, yeah. But also maybe the upper bits of glute max and the TFL muscle. If they're not strong enough to control the femur, it can drift inwards.
Okay, so weak hip abductors can lead to knee valgus. What about the tibia angling out?
The paper suggests that could be driven by things like excessive foot pronation or maybe just general looseness or poor control at the ankle.
Or could it be the tibia compensating for the femur moving inwards?
Yeah, they mentioned that too. It might angle outwards to try and keep the foot planted or balanced when the femur is adducting excessively. It's all tied together.
Are there structural things that contribute to?
Yep. They mentioned coxavara at the hip, where the angle of the femoral neck is smaller. That can predispose someone to a valgus knee alignment.
And pelvis width.
Right. Someone with a naturally wider pelvis might just have a greater valgus angle at their knees, simply to bring their feet closer together for a normal stance width.
And a wider pelvis would also mean those hip abductor muscles have to work harder to keep the pelvis level.
Yeah, exactly. It increases the demand on them.
So if you have a wider pelvis and weak hip abductors,
you could see that classic pattern. When you stand on one leg, the opposite hip drops, and the stance leg collapses inwards into valgus. It's that chain reaction again.
Wow. Okay, so this paper really paints a picture of PFP being potentially influenced by mechanics all the way from the foot up to the hip and pelvis in multiple planes of motion.
Absolutely. It's way more than just looking at the kneecap itself.
Which leads perfectly into the clinical implications,
Yep,
right?
yeah.
What does this all mean for actually assessing and treating people?
Well, the big call to action from the paper is for better classification systems for PFP.
Meaning grouping patients based on their underlying issues, like foot-driven PFP or hip-driven PFP.
Exactly. Instead of just treating all PFP the same, we need to identify why a specific person has pain. Is it their foot mechanics, hip weakness, femoral rotation issues?
Which means the assessment needs to be way more thorough, not just poking around the knee.
Right. You need to look at how someone moves. Gait analysis, watching them squat, step down, maybe even jump or land. Functional movements.
To see if those patterns of excessive rotation or valgus show up.
Precisely. But, and this is important, the paper also reminds us that not everyone with PFP will have these obvious biomechanical faults.
Right, so you can't just assume. You need to actually look and test.
And then if you do find something, say excessive knee valgus, the next step is figuring out the source.
Is it a structural thing they were born with, which might be harder to change with just exercise?
Or is it more about muscle weakness or poor neuromuscular control, basically, their brain not telling the muscles what to do correctly?
Because those things are potentially fixable with the right rehab.
Exactly. They use that example of medial collapse, the knee caving in during stair descent. Figure 5 shows it.
Yeah.
That pattern could be driven primarily by the foot ankle rolling in too much, or it could be driven by weak hip muscles letting the femur adduct and internally rotate. Or
A combination of both.
Totally. So you can't just give everyone with medial collapse the same exercises. The treatment has to match the specific underlying cause for that individual.
It really highlights the need for personalized assessment and treatment.
Definitely. So wrapping this all up, what are the key takeaways for our listeners from this deep dive?
Well, I think the biggest one is just how interconnected the lower body is. That knee pain you might be feeling, it might not be just about your knee.
Right. What's happening at your hips, your pelvis, even your feet and ankles can have a real significant impact on your patellofemoral joint. Things happening far away can influence the knee.
But we also need that dose of nuance, right?
Mm-hmm.
The research, as the paper points out, suggests these biomechanical issues aren't universal. Not everyone with PFP has excessive pronation or weak hips.
Good point. So while treatments targeting the hip or the foot can be really helpful for some people,
They won't be the magic bullet for everyone. It depends on the individual specific issues.
still, just understanding these potential links is powerful, isn't it? It helps you think more holistically about your body.
Absolutely. It encourages you, the listener, to maybe pay more attention to how you move. How do your feet land? Do your knees track straight when you squat? Noticing patterns is a good start.
Yeah, just being more aware of your own movement habits.
And maybe it prompts a bigger question, too. Given this interconnectedness we've talked about with the knee, what other seemingly unrelated body parts might influence other common aches and pains?
Ooh, that's a great thought provoker. Like, could neck tension be related to shoulder issues or back pain to hip mobility, stuff like that?
Exactly. It reminds us the body is a complex system, not just isolated parts. And the source of a problem isn't always right where the symptom is.
So if you are dealing with stubborn knee pain, maybe it's worth looking beyond the knee itself. Consider the whole chain.
Explore some biomechanics. Maybe get assessed by someone who looks at the bigger picture of how you move. It could open up new avenues for feeling better.
Great advice. Well, that was a fascinating dive into lower limb mechanics and knee pain. Thanks for joining us.